The information offered in this program by the host and guests is intended for educational purposes only and does not constitute medical advice from Osmosis from Elsevier or the Mount Sinai Health System. The determination of the need for medical services and the types of healthcare to be provided to a patient are decisions that should be made only by a physician or other licensed healthcare provider.
Hi, everyone. I'm Dr. Raven Baxter, your host of this episode of the Raise the Line podcast. I am a molecular biologist and director of science communication at the Cohen Center for Recovery from Complex Chronic Illness at the Icahn School of Medicine at Mount Sinai Hospital. And at the center, we work to advance treatment and knowledge of long COVID, tick-borne and vector-borne illness, myalgic encephalomyelitis, chronic fatigue syndrome, and connective tissue disorders like hypermobile Ehlers-Danlos syndrome. Post-acute infection syndromes are characterized by persistent symptoms that last for months or even years after the initial infection has been treated. And so in this episode, we're focusing on the clinical manifestations of post-acute infection syndromes, specifically those involving vagus nerve dysfunction, POTS, dysautonomia, and various cardiac manifestations. So thank you both for joining us today. I want to introduce both of you. Dr. David Putrino is a physical therapist, neuroscientist, and the director of rehabilitation innovation at Mount Sinai Health System. He's been actively involved in developing new technologies for rehabilitating patients with neurological disorders, including those involved in post-acute infection syndromes. David's a physical therapist with a PhD in neuroscience. So he's worked as a clinician in Australia before moving to the U.S. to study computational neuroscience at Harvard. Okay, wow, MIT and NYU. Heavy hitters here. He has served as a faculty member at Weill Cornell Medicine and Burke Medical Research Institute. And another one of my coworkers is here, Dr. Jenna Tosto, a leading expert in neurophysiological rehabilitation and researcher in the field of dysautonomia and cardiac manifestations related to post-acute infection syndromes. Dr. Tosto is currently spearheading innovative research at Mount Sinai, focusing on developing new therapies and innovations that could significantly improve the quality of life for patients dealing with challenging conditions. Her work hasn't just pushed the boundaries of our understanding, but it's also offered hope and actionable solutions for countless individuals. Thank you both for being here today and sharing your expertise. I have the pleasure of working with both David and Jenna at CORE, so I'm excited to learn from both of them today. Great. So yes, without further ado, let's talk about these clinical manifestations. I would love to cover the basics of what our medical students need to know about the various presentations of post-acute infection syndromes. This is episode 7, so they've heard a myriad and spectrum of various manifestations, but specifically these were referring to the autonomic system. What presentations can occur?
So for folks who have dysautonomia, clinical manifestations and clinical symptoms can be really variable. There are some hallmark presentations and hallmark diagnoses that we see in dysautonomia. So things like postural orthostatic tachycardia syndrome, or POTS, where individuals experience significantly higher heart rates with posture change or standing, as well as things like orthostatic intolerance or significant hemodynamic changes that occur with postural change. Folks can also experience a myriad of different symptoms, some that are classic to dysautonomia, things like fatigue and myalgia and pain, as well as some that folks might not have traditionally associated with dysautonomia, things like GI dysfunction and cognitive changes and brain fog. So really a wide spectrum of different symptoms and different clinical presentations.
And David, any thoughts to add?
No, I mean, I think that was really comprehensive. The only thing that I would add is that disorders of the autonomic nervous system are frequently misdiagnosed. Even prior to COVID, people would come to us with dysautonomia, which for those of us who see a lot of dysautonomia, it was very clearly dysautonomia. But, prior to their diagnosis of dysautonomia or POTS, they had been given anxiety diagnoses. They had been given, diagnoses like multiple sclerosis because the physicians or clinicians that were managing their care kind of knew that something was going wrong, knew that it was neurological, but didn't quite know how to appropriately diagnose. So a lot of individuals with disorders of the autonomic nervous system that require medications, targeted medications or targeted therapy are quite often misdiagnosed as having a psychogenic condition or having some sort of other neurological disorder before they finally make it to, a diagnosis of dysautonomia. So I would ask for all medical students to just be aware of that. When somebody comes to you and says, hey, I used to be an athlete, but now when I stand up, my heart is racing in my chest and it feels like I'm going to pass out. We've been trained to sort of go for, hey, that sounds like a panic attack. But often this is a hallmark sign of dysautonomia, and there are things that you can do to do a full workup to test for it.
Thank you. And along those lines, as a provider, what are some of the things that you hear from patients that will cause you to want to investigate and go down the route of autonomic function testing?
Typically one of the things that I'm on the lookout for is sudden onset of these symptoms. So folks who fit a diagnosis of a generalized anxiety disorder or another psychological diagnosis, often these symptoms don't just suddenly emerge out of nowhere for no good reason, or suddenly emerge after someone's been sick with COVID or sustained a concussion. It's not impossible for that to happen, but it's not the norm. So, one of the first things that we look for is symptoms that are happening that can be tied to a triggering event. The other thing that we sort of look for is, systemic symptoms as well. We often see temperature dysregulation. We see sleep disruption. We see GI disturbances. We see a lot of symptoms that can be tied to vagus nerve function that are emerging in addition to postural orthostatic tachycardia syndrome or POTS and, simple, I feel dizzy when I change positions, et cetera, et cetera. So we're really trying to keep an eye out for some of these holistic symptoms where we're also trying to understand what are the things that trigger these symptoms. Because again, when we think about psychogenic symptoms or when we think about, symptoms that will trigger things like MS, it's not the same as dysautonomia. With dysautonomia, it's like you're triggering symptoms by standing for too long. You're triggering symptoms by being in hot, humid environments. You're triggering symptoms by being dehydrated or way too hungry, because you haven't put your autonomic nervous system on a schedule that doesn't result in vast changes to sympathetic or parasympathetic tone. We really just try to take on a good history of what people are experiencing, and also specifically what is making things better or worse for them is very important as well.
Thank you for that. I would like to get deeper into some of the root causes of this. I guess for some context, as you all know, I'm a long COVID patient myself, and going into the treatment room and you're listing off all of these things. I have stomach problems. I can't sleep. My heart is out of control. I can't really stand. Like, the doctor will want to refer you to, okay, go to the GI. Okay, go to the neurologist. Okay, go to the cardiologist. And that can be overwhelming. So what should medical students know about the root and how to help the patient without simply just throwing them to the next specialist? What should they know about the root of these manifestations?
Yeah, it's a good question, and it's a challenging one as well. I'll say a few things and we can go from there. But first and foremost, some early autonomic testing is easy to perform to sort of establish if someone has POTS. And really, I would hope that most physicians, given how common POTS is and given how life-changing and debilitating it can be, things like an active stand test, which take 10 minutes, let's be fair, like 15 minutes for a clinician to perform, where you're literally asking someone to lay supine for 2 minutes, measure their blood pressure and their heart rate, sit on the edge of the bed for 2 minutes, measure their blood pressure and their heart rate, and then lean against a wall for 10 minutes and measure what is happening to their blood pressure and their heart rate every minute for 10 minutes. This is something that is so easy to perform that can capture a lot of autonomic dysfunction all in one test, and you shouldn't need to refer off to a cardiologist or gastroenterologist or, whatever the case may be to identify someone who may have significant autonomic dysfunction. Now, why does autonomic dysfunction occur in post-acute infection syndromes? The answer is not that we don't know. The answer is that it can be variable in different cases. So because post-acute infection syndromes, as we know, just really affect every single organ system and have so many vast effects depending on who you are and what your genetic history is and what your infection history is and so on and so forth, there can be many ways that it affects the autonomic nervous system. For instance, one of the simplest ways it can affect the autonomic nervous system is that many folks with post-acute infection syndrome have a heightened level of inflammation in their bodies. This can be because of a mast cell activation syndrome. This can be simply because they've gotten sick and they're experiencing cytokine storm or just elevations in systemic cytokine production. Cytokines and excess inflammation will trigger the vagus nerve, and it will produce vagus nerve overactivity, which can push you into dysautonomia. Similarly, there's been some recent studies in people with long COVID that have shown that we know that in many cases of long COVID, there is viral persistence. The SARS-CoV-2 virus persists in the body. There's been a few recent studies showing that persistence occurring in the gut can actually lead to infection of the vagus nerve. And so the vagus nerve itself gets infected by persistent virus, causes inflammation specifically of the vagus nerve, and therefore leading to dysautonomia. So there are lots of different ways that post-acute infection syndromes, from direct infection of the vagus nerve all the way through to just irritation of autonomic nerves based on chronic and sustained inflammation, where you can go on to develop autonomic dysfunction. The other thing that I do want to say, though, which I think is also important, especially for medical students to hear, is I think it's important for us to track the symptoms of people with dysautonomia and, not just see zebras, although at this point, given how common autonomic dysfunction is, I don't know what's the zebra and what's the horse, but, even if you're pretty sure that someone does have dysautonomia, if they're a previously healthy 30-year-old individual saying, hey, I'm getting heart palpitations, I feel like my heart is racing 1 minute and I'm going to pass out the next if I change my posture, that should be investigated by a cardiologist because, it will be more rare than dysautonomia to have a cardiac condition, but you want to rule it out. You want to clear it. You can suspect dysautonomia. You can even see signs and symptoms of dysautonomia, but it's still always important to rule out the other things that could be causing the symptoms that someone is presenting with. And so I do always recommend, I know it's overwhelming, but I do always recommend that if there's something that is bothering the clinician, a 30-year-old patient shouldn't feel these crazy heart palpitations and like they're going to pass out. We all agree on that. Even if you're sure, 99% sure that they've got dysautonomia, check the heart. Get an EKG, get an echo. Just make sure that your patient is safe before proceeding.
With that being said, I'd like to touch on physical therapy approaches in this case because it can be very touchy when there are cardiac manifestations of the post-acute infection syndrome, and also just POTS in general can be tough to maneuver physically. So is that something that you'd recommend a general physician to address, or would you rather them refer out to a PT?
I think anytime we're talking about implementation of physical therapy interventions, we want to be referring to our colleagues in physical therapy. This is precisely their expertise and their training. And so I highly advocate for that, especially underscoring in this patient population, and frankly, across patient populations, the value of interdisciplinary collaboration. I think creating team support for our patients is incredibly important as they navigate this. I think we've already in the first few minutes of this podcast established that this is a really complicated situation. So I think underscoring that interdisciplinary team is key. And to the point, referring to physical therapy is always a really valuable value add if the physician or medical team thinks that it could be indicated for the patient. Now, with that said, I think there are nuances to implementation of appropriate physical therapy interventions, because what we've seen for folks with post-viral dysautonomia secondary to a post-viral condition, some of the standard or what we can consider to be gold standard interventions for other forms of dysautonomia are not well tolerated in the population. And one of the key things that we are always mindful of as we implement physical therapy and movement-based prescription for rehabilitation largely is the risk for symptom exacerbation. And so that can be anything from post-exertional malaise, post-exertional fatigue, or just generally post-exertional symptom exacerbation. So oftentimes when both providers and patients and caregivers alike hear physical therapy is coming into play, there's some hesitation there. And I think underscoring for all disciplines that when we're implementing physical therapy interventions to address dysautonomia, we really want to be mindful of implementing strategies that are symptom titrated. So really considering the patient symptom burden and being mindful that the interventions that we implement keep in account the risk for post-exertional symptoms, both in session while they're working one-to-one with a therapist, but also in the hours to days thereby after. So really important to consider.
Yeah. And I would love to just add to that. I think that's so important, but I just hope that this is something that medical students can really internalize. One of the concepts that I think is so often missed about autonomic rehabilitation is we're not trying to improve cardiovascular fitness with autonomic rehabilitation. We're trying to very deliberately and slowly retrain appropriate autonomic responses to postural changes and to light exertion. So things like walking once someone has gotten quite advanced. We don't even start autonomic rehabilitation in an upright position until someone's quite advanced. And this transcends pre-illness fitness levels of our patients. So we have had performance athletes with POTS where we need to start them supine lying, even though if you ask them to jump up and run 5 miles, they could do it, and they could do it at a pace that would put, all of us casuals to shame. But, the point being, they would then pay for it afterwards, because the goal of our treatment is not to improve their cardiovascular fitness. The goal of our treatment is to retrain these appropriate autonomic nervous system responses, which means working them at an exertional level that doesn't feel like they're working out. And we say to them, yeah, you're not working out. That's why it doesn't feel like you're working out. You're doing a very specific form of rehabilitation that is completely distinct from exercise, which is, let's be real clear on definitions. Exercise is physical activity that is performed with the intention of improving physical fitness, cardiovascular fitness. We're not doing exercise when we talk about autonomic rehabilitation. We're doing a form of rehabilitation that retrains the autonomic nervous system. Some of it can look like exercise, which is where people get confused, but it's not exercise.
Thank you. Yes, and that reminds me of my own experience going to a long COVID clinic, and my physician was recommending that I do opera training. And he was mentioning breathwork, and I said, well, I'm not having respiratory issues, though. But he failed to explain that part about the breathwork is involved in retraining the autonomic functioning. So, I think it's really important that doctors are able to explain that to the patient before referring out, so as not to make the patient feel dismissed or misunderstood. Sometimes it just comes down to miscommunication. So, I also would like to get into, if you all don't mind or can speak to this, is there a role in diet and nutrition as far as treating these disorders and diseases?
Yeah, absolutely. I think there's a little bit of, when we talk about diet and post-acute infection syndromes in general, there necessarily has to be overlap with other aspects of post-acute infection syndromes. So things like mast cell activation syndrome and other conditions that can cause food sensitivities. But if we take that away, because I think that is complicated, and I know that there will be other podcasts that cover these other issues. So if we take that away, when we are advising folks with autonomic dysfunction, we're trying to, as we're rehabilitating the autonomic nervous system, we're trying to take away any sort of a situation that would cause a rapid change in their kind of autonomic status. So, as we probably should discuss, and as medical students hopefully know, the autonomic nervous system generally has two modes. We've got the parasympathetic nervous system and the sympathetic nervous system. The sympathetic nervous system is your fight-flight, and your parasympathetic nervous system is often referred to as your rest and digest. And your body sort of goes between these two modes throughout the day, depending on your daily activities. And in people with a healthy autonomic nervous system, it's more like a very fine-tuned dial. So you do something like you have a drink of water, and maybe that dials your autonomic mode, in one direction or another, from fight-flight to a little bit more rest and digest. In folks who have dysautonomia, that dial disappears. It becomes a switch. So suddenly, rather than being able to your nervous system being able to very finely tune where you are in this balance of autonomic function, you just go, oh my God, you just ate a bite of food. Clonk. We're going to put you into rest and digest. And we often talk about it as postprandial fatigue, extreme fatigue after eating. You feel like someone just put a ketamine blow dart in your neck and you can barely keep your eyes open. You're just, down. So as we consider that and as we think about that, one of the sort of bits of advice that we give in terms of the role that nutrition plays is really trying to avoid any situation that is going to cause that big switch to happen. So avoiding big meals, avoiding big intakes of fluid, and rather trying to space what you're doing out over lots of period of time. And again, as you pointed out, Raven, it's so important to explain to people, this isn't a cure. This isn't, we're not saying that you've gotten sick because you're not spacing your meals. What we're saying is that spacing meals and spacing hydration while your autonomic nervous system is vulnerable and exposed right now is going to reduce the probability that you have one of these big surges of autonomic function that cause you to feel extreme symptoms until we can get a handle on it and improve training. So, I think that just that understanding and that strategy of spacing meals and making sure that you maintain adequate hydration, usually with electrolyte supplementation, becomes super important from a POTS and dysautonomia standpoint. It's crucial and essential education for the patient population. Electrolytes can literally rescue a person from feeling as though they're not able to stand up or be upright without feeling like they're going to pass out.
Wow. Well, my mind is blown simply because you just helped me realize that probably the reason why at the height of my post-acute infection illness, I was having panic attacks while I was eating. And I went like a good month, 2 months where I couldn't get down a full meal without having a panic attack. And so I realized when I started eating smaller things like 1 carrot instead of 5 carrots, I could eat. So yeah, that's actually really, really fascinating. And it's just a testament to how sensitive the body is and how interconnected everything is. Wow. Going to the electrolytes, can you talk a little bit about the science behind electrolytes and POTS specifically? Because I think that knowledge was especially helpful to patients who are just trying to manage on their own, things that they can try to do at home.
So as with many things to do with POTS, there's often a lot of complex reasons why there's blood volume loss in people with POTS. There's a loss of fluids in people with POTS. So there's been some really interesting literature around altered function in sweat glands, which means that people with POTS lose a lot more fluid and lose amino acids at a more rapid rate, essential amino acids at a rapid rate compared with people who don't have POTS. There's also just changes in people's hormonal cycling and, producing things like aldosterone levels that can lead to fluid loss and blood volume loss. And so hydration becomes really, really important. Whatever the reason for the loss of fluid or the loss of blood volume, from deranged sweat glands all the way through to, endothelial dysfunction, the main thing that we've seen is that folks really respond quite well to making sure that their fluids are, first of all, adequate, that they're taking on adequate fluids on board, but those fluids are also fortified by electrolytes. And, typically it's as simple as just adding sodium to their water or to their fluid intake. There's a lot of brands out there that we recommend in clinic that really just take the guesswork out of it. They're designed for people with POTS, and they're available online, and you really just need to follow the instructions and typically just start to play around and work out what is right for you in terms of the amount of electrolytes and the amount of fluid that you want to take on every day. The only caveat here, I'll say again, is that we really want to make sure that both the patient and the physician understand your blood pressure status, your sort of cardiovascular health, because obviously you don't want to be taking on thousands of milligrams of salt every day if you have blood pressure issues, and or you want to manage those blood pressure issues with blood pressure medications so that you can take on the appropriate amount of electrolytes and fluid and feel good without worrying about, what your blood pressure is going to be doing. So often, we don't blanket recommend sodium supplementation and fluids. We first want to look at what their blood pressure history is and how their blood pressure is managing, and work in collaboration with the physicians before making those recommendations.
Thank you. And so what other lifestyle adjustments do you think that patients might be in for once you're able to diagnose them with one of these manifestations?
I think this kind of builds off of what David just explained. So when we take the case, let's use POTS as an example, right? The example I always give to patients is the idea that if we think of our bodies like a fluid-filled tube or a water bottle, when folks are laying down, we have equal homeostasis, right, across that fluid gradient at our head, our heart, and our lower extremities. When we come to stand up, we're contending with gravity, right? And so in a functioning autonomic nervous system, we would see a feedback loop, everything from our baroreceptors and our arches of our aorta and our carotid bodies, sending messages up to neural centers that control for vascular tone throughout our bodies in order to maintain that homeostasis. But for someone who has POTS in this case, we largely see that feedback system is impaired. So one of the really helpful techniques, in addition to fluid supplementation and sodium supplementation, like David just described from a volume loading perspective, even simply waiting moments, if not minutes, when they change positions. Wait for that period of hemodynamic stability. See if that heart rate response, and every patient by patient tends to find where their heart rate thresholds are. So if they come from a laying down position to sitting for a period of time, it really allows that added time for the integrity of the autonomic nervous system, despite the fact that it's not, functioning at its normal capacity, to somewhat regulate. Similarly, other things that folks can implement to really just help with management of their symptoms from a lifestyle perspective is energy conservation and pacing strategies. And the concept of energy conservation largely is, some folks will use spoons as an example, some folks will use energy envelopes. But really what it comes down to is we have an allocated amount of energy per day that we can expend on our day-to-day tasks. And so what pacing strategies largely suggest, or energy conservation strategies suggest, is that if we know what's coming in a day, we can allocate our energy appropriately and provide ourselves with necessary rest breaks, provide ourselves with necessary boundaries so that we can maximize the energy that we have without really exceeding that energy envelope or using all of the spoons for a day. I always caveat that with the reality that life happens in between all of this. And there are instances where those strategies are not always able to be easily implemented. But nevertheless, I think for folks who have a really good understanding of their energy envelope, implementing these types of, day-to-day lifestyle modifications can be really helpful. And then I think it circles back, right? We talked about dietary changes and just behavioral changes in that essence. I think all of that can be really, really helpful.
Thank you.
If I could just add in a few other observations on my end, I totally agree with everything that Jenna's been saying. And just a few of the other things that we've noticed have been the extent to which folks with POTS and dysautonomia can control their environment can be really, really helpful. So sensory inputs can be taxing on an autonomic nervous system, especially one that is under stress. So, people can be photosensitive, people can be sensitive to auditory cues, and, just general sound pollution can cause enough background stress to trigger the autonomic nervous system. So when folks are having a very bad time with their symptoms, the ability, if possible, which, let me be clear, it's a really privileged ask to be able to control light and sound in your environment, but if possible, it can be really game-changing for symptom burden. Similarly, heat. A lot of our people with autonomic nervous system dysfunction can have their autonomic nervous system triggered by heat. Heat causes your heart rate to increase, and as your heart rate increases, you run the risk of your body, especially if your autonomic nervous system is not working so well, your body saying, oh, I know what a heart rate increase is. We're exercising or we're fighting. So that big switch comes back into play, and, we're switched back into that sympathetic nervous system drive. So those sorts of environmental changes can be really beneficial if possible. And then I also think it can feel a bit taboo saying this, but we all need a bit of a shout out for just emotion regulation and avoiding sort of socially stressful situations, because a lot of folks with dysautonomia struggle with this, and this has been a point where they get gaslit by their medical providers as well of, see, you're getting emotionally upset and your symptoms are getting worse. That must mean that your symptoms are psychogenic. Actually, no, the autonomic nervous system is also, tied to the emotional experience. So if you are getting emotional, your heart rate's going to increase. If your heart rate increases, it's just like exercise, right? It's going to click your nervous system into a sympathetic drive, and you're going to feel much more strongly than someone who doesn't have dysautonomia the consequences of that. And so very complete for a clinician and especially a physician to explain to patients, like, right now, emotions are going to weigh heavily on your body, and you do need to avoid emotional situations. You do need to, in many cases, work with a therapist to discuss emotion regulation techniques that we know you didn't need before your POTS or dysautonomia diagnosis, but now you do, because you don't want to be stuck in a sympathetic state for the rest of the day and be unable to sleep because you had a stressful meeting at work. You want to be able to have emotion regulation strategies in place that help you through that, so that you can properly manage this new condition that you've been diagnosed with. So understanding that stressful situations and emotional dysregulation can trigger autonomic events, and that doesn't mean that dysautonomia is psychogenic. It just means that it's one other trigger that can cause problems, and a complete clinical strategy for dysautonomia includes these. We don't shy away from it and be like, oh, let's not bring up psychological issues with our patients. It's, it's just important to fully explain why.
That was amazing. Thank you so much for that. And I guess just to offer my own patient perspective as far as lifestyle changes, it can range. There may be some days where you simply just can't get out of bed and can't even go to the bathroom. Like it could be as extreme as you need a urinal next to your bed, or you need to plan out how many times you're actually going to get up in a day. To, at one point, I could only look at TV or watch TV if I had earplugs in, and I could barely hear it, and have sunglasses on so that there was not a lot of light hitting my eyes. Or I would have to use a rolling desk chair to move around to make my food. And I actually didn't leave my house for a couple months because I couldn't get up out of the stairs. So, there's a lot of lifestyle changes. Definitely considering using mobility aids. That concept was new to me. Shower chairs, so I couldn't stand in the shower, especially with that hot water hitting me. My heart rate would be, it really felt unsafe. So I ended up either laying on the shower floor or sitting down on the shower floor, and eventually got a shower chair. Mind you, it's hard to get up off the floor from a sitting position if your heart rate is really erratic. So there's a lot of lifestyle changes that patients really just need to give themselves grace about, and not cause additional emotional stress by becoming disappointed with themselves. And I think it's just important to encourage the patient. It is normal to experience lifestyle changes when you're chronically ill. So reassuring that, you're doing the best that you can with what you have as far as your health, and things can improve. And that's what I want to talk about next, is recovery. So what can the recovery process look like for these chronically ill patients? I know every journey is different. There are ups and downs. Is it a general assumption that the trend can be upward, or is it just too diverse to really say what recovery can look like for all patients?
So I think you prefaced it with a really important statement that everyone is on their own individual journey. And I mean, clinically, we've seen, everyone follows their own path. The example I like to use with patients and those I'm educating largely is that symptom recovery is nonlinear for folks with dysautonomia. Generally, what we see is more of like a sinusoidal experience, right? Where you've got peaks and valleys, and those peaks are symptom exacerbations, and the valleys allow us for some degree of symptom stability. And as folks go through their recovery journey, what we're looking to do, right, is decrease the amplitude, right? Decrease the extent of those flare-ups and those crashes that come. And so what we're looking to do is stabilize things over time so that the number of flare-ups that happen are less frequent, the severity of those flare-ups are less frequent, and ideally we reach a point of symptom stability. So, as a therapist myself and in rehab, right, I always use the example as well. This is not like an orthopedic injury, like an ACL repair, if you will, where we have a surgical procedure. We have really strong evidence that says if you do X, Y, Z exercises, statistically, we feel really confident that recovery is going to look fabulous in 6 to 12 weeks. This journey is definitely a different one. And for folks who perhaps have had experience in other rehabilitation experiences throughout their lifespan, not related to their chronic illness, this idea might be new. So I think just kind of setting the expectations that we're looking for stability over time really is at the core of what we're looking for in this journey.
Can I also just add, I think a crucial piece of the puzzle here as well is having very switched on clinicians that identify when something isn't working as well. Because Jenna's so right, it's non-linear in terms of recovery process. What we're often looking for is this general improvement in function while symptoms are still occurring, but the symptoms are getting, less severe and less frequent. But I also think it's important sometimes, and we've all experienced this clinically, to identify, we've been trying for a while and we're not budging on your symptoms. And one thing I really admire about the program that Jenna has built is how focused it is on outcome measure collection, which we often, in rehab, we often kind of just squint at a person and be like, you seem to be moving better, or you seem to be, walking around with less pain, or you seem to be XYZ. It's so important with this population because, there's so much at stake in terms of overall symptom burden that if you feel as though something isn't moving, it's a referral back to the doc, and it's like, okay, well, maybe we need medications in addition to rehabilitation to address this. Maybe we need non-invasive brain stimulation. Maybe we need a stellate ganglion block. Maybe we need, XYZ. There are lots of options to try for folks with dysautonomia, but often what we see is that because there's not that level of attentiveness and communication with the patients, people just get demoralized and drop out because they're like, well, I've done 4 weeks of this rehab that is supposed to make me feel better. My clinician doesn't seem to really be listening to me when I say I don't feel any better, and anything other than trust the process, which isn't particularly useful, So I think as clinicians who are dealing with this, we need to monitor and be vigilant, and such a hard thing to do when people are feeling so unwell to ask them to engage in rehabilitation, because we're not talking about physically intense rehabilitation, but the process is taxing, and the process takes time, and the process takes sacrifice. Not even just engaging in rehab, but engaging in pacing is a sacrifice. You're asking your patient to sacrifice a lot. Now, if they've been pacing for 3 weeks, really denying themselves a lot of life experience and time with their kids and, you name it, and they're not feeling even a stitch better, like, it's time for a new strategy. It's time to try out medications. And I think that that's often missed is really checking in with your patient and making sure that they're getting benefit from what you're doing. And if they're not, change course. It's a really important piece.
I think that's super important. I would add on that and say it's really helpful for the patient to journal what they're going through, because when you're in the thick of a chronic illness, it's easy to get fazed by the really bad days and panic and say, well, I need intervention now. But if you look at the past 3 weeks and you say, well, I couldn't eat an apple 20 days ago, but today I had a burger and I didn't panic, and wow, I got up the stairs and yeah, my hearing is going out, but generally there is a trend upward with some of my other symptoms. There's a host of things to acknowledge that you might not be paying attention to or just might have forgotten that should be documented. So I just recommend that you encourage your patients to document what they're experiencing so that they can also play a role in monitoring their own progress. But would you both agree with these? You're the ones who are treating these people, so...
No, I think that's so important. And thank you for adding that in, because there are so many layers to post-acute infection syndromes and the symptom presentations, and you can stay the course on a particular treatment approach or interventional approach and actually make meaningful gains. But if we ask, how are you feeling? You still feel sick. So it's like, well, I still feel sick. Like, I thought this was meant to fix my issues, and as you were saying that, I was actually thinking of one particular patient that I was working with who was, very unwell, and we set some goals, and after a fairly long and grueling process, we were checking back in. According to my data, there was improvement. According to this individual, not so much improvement, and then we went, okay, well, let's go back over the goals, like when we started several weeks ago. And the patient had actually met every single one of their goals. But they were like, oh, well, I still feel sick. And it's like, that's okay, but we'll set new goals. And we'll check in on those goals in several weeks because, yeah, it is really frustrating to put your whole heart and soul into rehab for a little while. There is an expectation violation at the end of it of like, well, I wanted to be better by now. Like I wanted this to be the thing that was it. But, but if you do sort of check in and you do journal, you can actually see in real time the difference, and it can make you feel like you're making progress and give you the motivation to keep going.
Yeah, that I would also add, if the patient has access to these things, wearing a fitness device was incredibly helpful for me because I was able to see the trends that I didn't have the capacity to observe, like resting heart rate or active heart rate. What's it called, David? What's
heart rate variability?
Heart rate variability. Thank you. And also, my Apple Watch can measure like stability, and I was super unstable in how I was walking at the height of my illness versus 10 months later. You could see a trend where it was just like mind-blowing, the improvements that the fitness tracker could notice, but that I didn't even know. I didn't even know that I was unstable in not walking well. Or I didn't really realize that my resting heart rate was so high until it wasn't. So yeah, that was also super helpful. Okay, so we talked about recovery. I guess let's talk more about what does it look like when a patient comes to you, beginning, middle, end. How would you recommend the medical students approach the conversation just so that they have that tool in their pocket by the time they finish listening to this episode?
I think at the forefront of everything is listening to our patients. That is step one in all of this. I think that there is a tremendous opportunity, admittedly, to learn everything we need to know about our clinical plan of care and the path that we're going to go down by simply taking the time to listen and to hear what our patients have to say. I think that's at the forefront of it. And I think, for a medical student listening to this podcast or to really trying to upskill themselves in this space, there's a ton of evidence that exists presently. There's a ton of emerging evidence. So be a good consumer of the literature that's coming out in this space. Keep yourself informed and engaged. I have said to patients in the past 4 years, if we take post-COVID conditions as our example, or long COVID, right? We know more today than we did 1 year ago, 2 years ago, 3 years ago, 4 years ago. So the evidence is consistently coming out there. But I think in addition to listening to the patient, also listen to solid evidence. Be a good consumer of the evidence that's coming out as we start to inform our clinical judgments. And then I think really making sure that we're amalgamating all of that information in a succinct way that lends itself to developing a plan of care, but also be willing to pivot, right? To David's point earlier, we want to make sure that the interventions that we're recommending, we're monitoring their progress and we're actually being objective in the way that we mark progress. We're listening to patient symptom report, but we're also looking at objective granular data that can tell us if the interventions we're recommending are beneficial or helping our patients. So I think it's a bit of a triumvirate approach, at least in my mind, of like listening to what we've got from the literature, listening to our patients, and then just following data. That's kind of at the cornerstone of clinical care as far as I'm concerned.
Yeah, absolutely. And I want to take a minute to recognize that, like, for a clinical provider, it can be demoralizing. It can feel demoralizing to have a patient that is not getting better no matter what interventions that you throw at them. The only thing I'll say to the medical students listening to this is, well, imagine how that feels for the patient. Imagine how that feels for the person actually coming to you for care. So don't waste time on being demoralized. Don't waste time on, oh God, what am I going to do with this person? They're going to show up again and they're not going to be any better. Have a plan A, B, C, D, E, F, have many plans in place because, as Jenna mentioned, this is a rapid growth area. There is always one more thing to try. There is always one new paper that has come out in the last week. There is always one new strategy that you can adopt. And so be across that. If you want to be an expert in post-acute infection syndromes, you need to embrace the complexity. You need to get used to the fact that when something isn't working, anticipate that it's not going to be working. Go to the worst case scenario for the patient that is not responding as you would like, as most of the other patients are responding, and have multiple plans in place, because there's nothing worse from a patient perspective than showing up to the doctor saying, well, I'm not better anymore. And this kind of knee-jerk reaction of, I don't know, insecurity, hostility that it's not going to plan leads to, well, I don't know why you're not getting better. Maybe you don't even have this condition. Like, that's not helpful. That's defensive. That's not a way of managing a complex situation. So my number one, here would be, as Jenna mentioned, pivoting, always being ready to pivot, always assuming that there's at least a solid chance that your patient's going to come back to you at a 4-week follow-up and be like, I'm not feeling any better. What should I be doing next? And have an answer. That's the prep that you need, is like, don't just assume this is going to go smooth. It rarely goes smooth. So have an answer for, I'm not feeling better. What should I try next? And there's always something to try next. And I can't express how comforting it is for patients to be met with, okay, I'm sorry that last thing didn't work. Let's try this next thing. So that you've always got a plan, and it's an evidence-based plan that you're putting into motion.
Thank you. And are there any questions that I didn't ask that you would like to address?
Jenna, anything from you?
No, not on my side. I feel like this was a really comprehensive talk.
One piece from me is, I don't think maybe we got into it too deeply, but I can't understate the importance of breathwork and some of the benefits people get from breathwork with autonomic rehabilitation. I know you touched on it briefly, Raven, but one of our earliest publications in long COVID in the middle of the pandemic was that we showed that people with long COVID have lower levels of CO2 in their breath than healthy controls who didn't have long COVID. So low levels of CO2, even though the patients themselves were not hyperventilating. Usually when you see low CO2, you just assume that someone's huffing and puffing and blowing out all of their CO2. These folks had a normal respiratory rate, but their CO2 levels were low. And so when we started implementing breathwork strategies, we were implementing two things. We were trying to improve parasympathetic nervous system function, because we noticed that sympathetic overload was happening a lot in our patients. And we were also trying to increase carbon dioxide levels. And when we started doing that with patients, we started to notice significant improvements in overall symptom burden. It wasn't a cure, but it was something that helped patients really manage some of their severe symptoms. And so, we've really been doing a lot of work with breath work, and I love breath work because you can do it laying flat, you can do it sitting, you can do it standing, and it's a great symptom modulator. So often our whole autonomic process, we call breath work prehab. We start people off on breath work, even if we're not yet clear that they can engage in physical activity. So, if we're concerned about their heart and we're waiting on them to get an echo or an EKG before we start rehab, we can still do breath work with them, and it's nice and safe, and it still seems to have a benefit to their overall symptom burden. So we've done a lot of work on breath work. We've put out a lot of content, and there's a lot of great apps out there that train breath work for folks with long COVID and other post-acute infection syndromes. So I'd just say, don't sleep on breath work. It's really helpful and important.
Thank you. Yes, I definitely co-sign that. After being immobile for quite some time, you don't realize how much your body misses the opportunity to actually breathe, and breathe hard. And I'll never forget when I started doing the breathwork exercises, my chest was cracking because I hadn't taken deep breaths in such a long time, because I wasn't physically exerting myself. And so there was a lot of recovery that I had to do there. Highly co-sign and recommend breathwork, even if it doesn't make sense to you for whatever reason. It does work, and for all of the reasons that we shared in the episode. Well, thank you, everyone, for listening. Thank you, Dr. Putrino, Dr. Tosto, for these insights. It is clear, it's evident that the after effects of these infections can weave through various systems in the body and present complex challenges for recovery, but with challenges come great learning and great achievements. So I am praying and hoping that this expertise will illuminate your path to navigate or help your patients navigate these conditions. And I hope that they have brought more attention to the importance of comprehensive post-infection care. Thank you for listening, and we'll see you in the next episode.
If you like this podcast, please share it on your social channels. You can also subscribe to the series and check out all of our episodes at osmosis.org/raisethelinepodcast.